Well, good afternoon, everybody, and thanks for joining us. You've landed at the CAHF COVID monthly roundup. We're no longer doing the weekly roundups. A lot has happened this month. We're going to go over a bunch of different changes to AFLs, talk about the mandate. We'll talk about the booster recommendations that came out yesterday, or a combination of over the last 2 days. And then I want to talk about some issues with Los Angeles Department of Public Health. And if you're in Los Angeles, there were some changes that came out on the 15th of September. I want to make you aware of that, but also to let you know those changes, I think, are going to get changed back to what they were before. And Los Angeles County is going to have a webinar at 2 o'clock today. So I totally understand if you're in LA and you want to bug out a little bit early just to get logged into the webinar, because that's going to be an important one if you're in Los Angeles. And on the last slide today, I'll give you the link to register. I also sent it out as a forum notice, so if you check your email inbox, if you're on the forum, you should have gotten the link to register if you want. So with that, let's get started. It is September 24th. It's 1 o'clock. As always, any resources that we develop are housed on the CAHF.org website or the CAHFdisasterprep.com website. We'll talk about specifically the exemption resources and where they are on the website here in a second. My name's Jason Belton. I'm the Director of Emergency Preparedness for CAHF. And Patty may be able to join us a little bit later, but I'm not certain. I wasn't able to get confirmation from her. But normally we have Patty on as a guest speaker. All right, let's get started with our traditional introduction. The speaker's opinions expressed on this webinar are their own and may not reflect CAHF's official position. Where I give you my opinion, I will reflect where or if that differs from CAHF's official position. These webinars are brought to you part of a grant-funded program with the Los Angeles County EMS Agency and the California Department of Public Health. And I have no personal financial conflicts. I'm employed by CAHF, and there are no sales offerings on this webinar. The intent of the webinars is to give you a situational report of what's happening in the state in regards to the COVID response, some forecasting where we can for what's likely to come down, and highlight best practices where we can. And we'll talk about some of those as it relates to the exemptions here in a second. All right, so I mentioned a bunch of AFLs came out this month. I'm going to start with some of the ones that are easier. These two particular AFLs had to do with suspension of the CNA requirements and suspension of specific regulatory requirements for NATPs. Both of those temporary waivers have been extended to December 31st of this year. They may go past there, but they just extended them. They were set to expire at the end of this month, and they kept the waivers in there. And so there's a link to both of those. If you are on the CAHF forum, you should have received, generally when these AFLs come out, Patty and her staff will send a red line version that shows any differentiation from previous versions. These two were just the extension of the date. So I didn't include that in the notes. I didn't think it was that big of a deal, and I have a limit on how many handouts I can give you guys. So, all right, let's move on to the next AFL. All right, I think, did I go too far? No, okay, there we go. All right, so this is a big one. Obviously, AFL 2046. This is the third revision of this, I think. It's 46.2, and this just goes over the request for urgent staffing resources. We've talked about this ad nauseum about the process to do this. Let's talk for a second about kind of the reality of what's happening, and not just in the long-term care space, but in all healthcare, and what kind of conditions you can expect to see and how that can affect us maybe after 10/1. The hospitals, CAHF, have both sent letters to the governor, to the Attorney General's office, to Health and Human Services to ask for really direct relief on staffing waivers, as well as actions taking, trying to, rein in the exponential growth in costs by registries. And we've asked the Attorney General to get involved, and so has CHA. How those things play out, I'm not certain, but we've stepped up our asks, and we've made some pretty dire predictions for CDPH and HHS as to the availability of healthcare workers after the September 30th deadline. I think it's going to be a lot worse in certain areas of the state. That's possible. I'd love to hear, if you're in a rural county, what your plans are, or how many of your staff have already brought in, exemption letters. But we certainly are aware that certain areas of the state, just based on the demographics, those communities have lower vaccination rates. And since our staff live in those communities, those facilities that are in their communities also have lower vaccination rates. And for you guys, where maybe you're only at 40 or 60% of your staff, that's, that's a big jump to make between now and next Friday. So I'd like to know, what your plans are. I think CAHF wants to know, especially if you anticipate something drastic. If you have to depopulate your building, or you feel like folks are just not going to show up after that day, now is the time to reach out to us and let us know, so that we can work with the state partners to find you staffing resources that are not going to force you to have to evacuate, if that is your option. We want to try to avoid that. Hospitals, that they certainly don't want to see an entire facility of skilled nursing facility residents show up at their door just because the facility can't staff it. So I think the goal would be try to recognize where folks are going to need assistance standing up, whether it be for a day or 2 days or 3 days or 7 days or whatever. Now's the time to reach out to us so that we can work with the state and or the county to try to figure out what's best for the residents in the building. So there are a couple of handouts. One of the things in the AFL was really, really wanted to point out was that there is an expectation, if you didn't know this, that if you get staff through the state, you're required to pay them back at the state staffing contract rate. But I'll be honest, the state staffing contract rate is less than what I've seen that you're paying from, contract personnel, from registry. So, if you get the state staffing contract, I'm not sure that, you having to pay that is all that big of a concern. It is more than probably what you pay your standard CNA rates. So in the handouts today, I included what the state staffing contract rates are, so you can see what the breakdown is by CNA, LVN, RN, or any variation of a clinician that has a COVID rate all the way on the right-hand side of the thing. So in terms of how you access these resources and the terminology you want to use if you desperately need staff, you're gonna, you're gonna have to explore those staffing options. But if those staffing options are unreliable and it's going to put your residents at risk, I think that's how you need to coach this request. You say, hey, Mr. or Mrs. Mohawk, the reason why I'm requesting this is the level of care could drop if I don't have enough staff. I'm not even talking about meeting the 3.5 or 2.4. I'm just talking about, basic, is this going to be safe for those folks? If you can coach it in that request, it's more likely you're going to be successful in your request. But if you're not at that point, it's going to be really, really hard to get staff. And I mentioned the staffing issues with other agencies. EMS, which would be the primary agency that would, send out emergency staff like CalMat teams and things like that, they're seeing really large staffing concerns as well. And it trickles down to the EMS service within each community. So we may even see impacts to just basic emergency services within our communities based on what we know of the staffing issues with EMS. So the issue is not just us, and frankly, we might even be in a little better space than other healthcare providers. I know that's hard to wrap your brain around. We have a much higher vaccination rate in our staff than the hospitals do. The hospitals are very concerned about what's going to happen with this. But anyways, the handouts are there that describe the use or the cost associated with those. And then there's the, kind of schematic on how to request staffing resources through the state. All right. AFL 2134 is the AFL that came out that talked about the exemptions that are allowed and who is required to have the vaccine. We've gone over a lot of this, but I want to just kind of clarify who they consider, what roles they consider, and then you guys can think about who within your facility that this doesn't apply to. It's probably not many, but we'll see. So all paid and unpaid individuals who work in indoor settings where care is provided to patients or patients have access to for any purpose. That includes healthcare professionals serving in healthcare or other healthcare settings who have the potential for direct or indirect exposure to patients with SARS-CoV-2 airborne aerosol. All right, so I think we understand that, but what does that list look like? The list is pretty substantial. Nurses, CNAs, physicians, technicians, therapists, phlebotomists, pharmacists, students and trainees, contractual staff not employed by the healthcare facility. That's an important one because we have lots of those folks in our building. And then persons not involved in patient care, but who could be exposed to infectious agents that can be transmitted in the healthcare setting. And that includes clerical staff, dietary staff, environmental services, laundry, security, engineering, facilities management, administrative billing, and volunteer personnel. So the list is pretty darn comprehensive. I know that, some folks have like a corporate office, and maybe those folks in the corporate office don't ever go to a healthcare facility. They may be excluded from this particular order. Doesn't mean they're going to get out of the federal order once the federal order comes down. We still don't know a lot about the federal order. I'll talk about that in a second. But it's going to be most of your staff. It really is. All right. So in terms of who can be exempt from this requirement, so a healthcare professional may be exempt from the vaccination requirement only upon providing the facility operator a written declination statement signed by the healthcare professional stating either that they are declining vaccination based on religious beliefs, or the worker is excused from receiving any COVID vaccine due to a qualifying medical reason. Now, I've mentioned this before, but the qualifying medical reason has a kind of something that goes with that. It's not just you sign this form. To be qualified for the qualified medical reasons exemption, a healthcare professional must also provide their employer with a written statement signed by a physician, nurse practitioner, or other licensed medical professional practicing under the license of a physician. So they have to be, so if it's an RN or a PA, they have to sign it under the license of a physician. And that also means that if this person is not under the license of a physician, then that does not count. So I've had people talk about naturopaths, other non-traditional medicine, and while I'm all for exploring non-traditional medicine, in this particular case, it would not work for the exemption. It would have to be signed under the license of a physician. So, and then when the physician does it, only has to state that the individual qualifies for the exemption. The statement should not describe any underlying medical conditions or disability which causes the exemption. It should only indicate the probable duration of the worker's inability to receive the vaccine, or if the duration is unknown or permanent, it needs to be indicated. And that's important when we talk about these partially vaccinated people that have not been, that won't be complete by 10/1, but will be allowed to work, and we'll talk about that in a second. All right, so for those that are going to have one of those two exemptions, testing must occur for those folks twice weekly for unvaccinated workers in an acute healthcare and long-term care setting. So that means both SNFs and ICFs. And just as an aside, if you're using the Buy Next Now cards, or you were, or you had a plan to use them, and now the supply is dried up, there are new antigen tests that are approved, FDA, EUA approved. There's a link there to the list, the full list of new tests that are available. If you're a part of the state testing task force, that work group that has done the daily antigen testing, for you guys, there is a, they're going to start sending out the Care Start antigen tests that have a very similar performance to the Buy Next Now tests. They're going to send those out to you guys to use until the Buy Next Now supply can be restored. And then on the handouts, there's the EUA for the Care Start, along with the instructions on how to use it and stuff like that. Anybody that's using one of those exemptions is going to be required to wear a surgical mask or higher level respirator at all times in the building. I think we all know that. And then facilities will be required to maintain records demonstrating compliance. And Patty put out a nice note on the forum that kind of expanded on what those, what type of records you should be completing. But if you're, best practices for documenting compliance for that. So if you have questions about that, or you didn't receive that email, send me a note, and I'll send you the guide that she developed. All right, let's talk about vaccine timing, because this was a big thing that that came up during the webinar this week. Was there was some confusion as to whether whether somebody had taken a second dose prior to 9/30 would be considered compliant by the rule, and would they be allowed to work without the requirements to test twice weekly or wear a mask at all times within the building. And I think they had originally answered on the webinar, and I had to leave the webinar early, and I apologize, I missed that, and it caused some confusion. But the good news is CDPH kind of clarified that on the webinar, or on the conference call yesterday, and you may have missed that. And I want to, they're going to release a like a set of a flow chart that goes over 4 scenarios. I just want to cover those, but oops, sorry, I went too far. There we go. Sorry, apologize for that. So, so they did clarify that if the employee had received either the second dose of the 2-dose series or 1 dose in the 1-dose series completed by 9/30 is technically compliant with the health order. What should we do if somebody is in the process of becoming fully vaccinated? Let's say they get their last shot on Sunday, and then 14 days will be on October 10th, or whatever the date is. You go, oh, okay, well, from the time of 10/1 until October 10th, we are going to treat that person as an exempted employee. They would be allowed to work. There are going to be, kind of recommendations for, the types of work and work assignments that you should consider, but they're not required. And I think, I think a few of us highlighted the fact that we're going to have folks that are exempted working with no restrictions outside of the testing and the masking. With these residents, why not at least offer the same allowance for those in the process of getting vaccinated? And I think CDC agreed with us, and or CDPH agreed with us, And that's where they're going to release a flow chart that kind of describes this. And I want to go over the stuff that Dr. Epson has given me that I know will make the flow chart, but I wanted to give this information to you now so you don't have to, you know, let some of that stress settle back down. So vaccine doses that have been completed, meaning fully completed by September 30th, that those staff meet the criteria for full vaccination. They don't need to be routinely tested, you know, with the unvaccinated staff. Vaccine doses that have been completed by September 30, meaning they took their shot, you know, by September 30th, but they're not meeting the criteria for fully vaccinated yet because of the 2-week period. They're compliant with the order, but they need to wait 2 weeks because they're not fully vaccinated. I'm sorry, the answer she gave is a little clunky. These employees may work because these employees are higher risk. If you have severe immunocompromised residents, avoiding assigning these partially vaccinated staff could be reasonable. It's not a requirement, but it could be reasonable. So if you can, look for ways to minimize the risk, especially to immunocompromised residents, for sure, residents that have not been vaccinated. If you have an idea of who those folks are, you know, and you can schedule somebody's workflow or arrange their workflow so that it minimizes the risk to those specific residents, I think that's great. But none of this is explicitly required. They can work with a potentially lower risk assignment and need to have twice-a-week testing compliance until they meet the 2-week period. And then once they meet the 2-week period, then they're, you know, they go to option number 1. You know, no testing, or no screening testing, I should say. If you get an outbreak, you still have to do outbreak testing or symptomatic or anything. The individual is in process of being vaccinated, but they have not completed both rounds yet. And so that would be for somebody that was had taken the first shot, but had not even received the second shot yet. For these individuals, they're not quite compliant with the order, but we would like to balance compliance with the order and staffing challenges. If there are no staffing challenges or staffing shortage, we suggest that case by case, these individuals could work in areas with minimal contact with residents and other healthcare personnel until they are fully vaccinated. If there is a severe staffing shortage and the facility needs these staff, they could work with restricted assignment, but need to be in compliance with the twice-weekly testing. That all sounds reasonable, and it sounds a lot better than no, they can't work and they have to be excluded. And then lastly, the individual is unvaccinated and they have an exemption granted. These staff are compliant with the order and may work. They are a higher risk group of employees and there is no requirement for restricted assignment. If there is a lower risk assignment, that definitely can help. I added in that definitely can help. They need to meet twice weekly testing, and if there is no exemption granted, these employees may not work and recommend that facilities facing staffing shortage contact their local health office to get staffing support as we move past the September 30th deadline. And that's important. Hopefully you guys have some understanding of how many of your staff are left to, you know, to give you an exemption. I will say that there was a lot of talk about the exemption specifically, and maybe even a more broad view of what could be allowed under the religious exemption was given on the webinar yesterday. Now, this is information that was provided me by CalTCM. It's not something that CAHF would has necessarily weighed out to see if this is the appropriate legal standing. And I talked to our general counsel this morning, who mentioned that it is okay to mention this, but just to realize that this is being viewed differently all across the country, and we're kind of flying, we're walking on a tightrope without a net underneath us, and we and at this point, I think we've seen a real broad acceptance of what would constitute a religious exemption. And I want to read to you This is information that Dr. Lamb provided to me. It's information that will be in the notes on the call when they send them out. But in any cases, this is a quote from the EEOC. In most cases, whether or not a practice or belief is religious is not at issue. However, in those cases in which the issue does exist, the Commission will define religious practices to include moral or ethical beliefs as to what is right and wrong, which are sincerely held with the strength of traditional religious views. And that's a pretty big departure from some of the other stuff. And there's a link to the where you can find that information on the EEOC. I'll say that, you know, CAHF has created a number of sample exemption templates. If you go to CAHF.org and go to the legal section, we have an explanation of what's kind of a guidance on each one of the forms that we develop, as well as multiple different choices for medical exemptions and religious exemptions. If you're in this category where you and your counsel have determined this is the case law that we think is standing here, we're going to use a less prescriptive sample template. The very first one that's listed as Form A on ours is very basic. It does not require a whole lot, and this would seem to fit in with this particular view of the ruling. And then we have templates that ask staff to expand a little bit more. Like I said, I'm not an attorney. I can't give you advice as to which one I think is better. I'm more of an operations guy and a realist, and I think, man, I need to keep people in the building. That's my main concern, especially if I got 30 or 40% of my staff that are not vaccinated, and I'm staring down the barrel. I might be more inclined to use another form, and I don't know. That's a conversation that you and your leadership are going to have to be candid about, to see which one of the forms you want to use. I don't know. I can't give you an example. I can only tell you that we've developed multiple ones for you to make your decision. So hopefully that helps. If you need any of the example forms, I know we had some difficulty with the website. Just reach out to me, jbelden@caf.org, and I'll send you what we've got. So, and then on the webinar next Wednesday, CDPH is going to go over that flow chart. They're going to put it in, hopefully, something that's easy for us to print off and put to good use right away. All right. So AFL 2136 came out, and that just talked about the space conversion for blanket waivers. And I think this assumes that we've got enough staff to add capacity to our facilities. But in any case, there could be scenarios in which if you're a company and you know that you're going to have issues staffing one building, you may think about combining two buildings and putting staff in, combining all your staff from the two buildings into one to make sure that you have enough staff to staff the building. If you're at that point where you're thinking, God, I got to depopulate some of my beds, or I have to close, or anything like that, and I could see a scenario in which you could have to possibly expand your bed capacity in order to deal with somebody that did that. But I don't think that's likely, but this is available, just so you know, and that blanket waiver expires again at the end of the year. All right, so both the state and Los Angeles County and many health departments have sent out BYD N95 respirators. Many of you have purchased BYD respirators. The other day, CDPH issued an AFL about a small subset of the BYD model number DE2322 N95 respirators. They're no longer approved for use as an N95. So there are specific lot numbers to those types of respirators. And there's a chart, like a PDF, that lists each one of the lot numbers. And that's the bottom link there. If you click on the link, you can go through the lot numbers and figure or pull your lot numbers from any BYD mass that you have. And if you're in that lot number, you're going to have to either use those as source control or just get rid of them altogether. All right, let's talk about the big news, because this came out yesterday. This is exciting stuff, I guess. You know, it's good news for our residents for sure. So yesterday, well, we know the third shot has already been approved by the FDA and ACIP for immunocompromised folks. Yesterday, ACIP finalized their recommendation for booster doses, and I'll go over what those recommendations are. And that came on the heels of the FDA approving or recommending booster doses. If you're interested in the slides from the ACIP meeting, they're pretty lengthy, but the length is there. There's, I don't know, 20 presentations, and each one is pretty in depth. So, but by all means, the reasoning behind the recommendations are listed in the ACIP meeting notes in the slides that they provided. And then I'd like to, if you guys have not used CIDRAP, or you're not familiar with that, I like CIDRAP. It's the Center for Infectious Disease Research and Policy at the University of Minnesota. CIDRAP has a great collection of resources around COVID-19, and they have a ton of good resources. This is more higher level stuff, but there's a great article about the booster shots in there. As far as we know, you should be able to start ordering from your long-term care pharmacy soon, if not today. And I'm going to go over the media release that CDC recommended, but there's CDC released, and there's the link to the booster recommendations. But there are 4 recommendations that the CDC came out with after the meeting. 1, people 65 years and older and residents in long-term care settings should receive a booster shot of Pfizer BioNTech's COVID-19 vaccine at least 6 months after their Pfizer BioNTech primary series. So that, for most of us, we're in that window now. So you start heading that direction for those folks. People age 55 or 50 to 64 with underlying medical conditions should receive a booster shot at least 6 months after their primary series. People age 18 to 49 with underlying medical conditions may, so not should, may receive a booster shot at least 6 months after their primary series, based on their individual benefits and risks. And so if you've got staff, and that's where this is different. So the FDA recommended that they include staff that work in high-risk settings, meaning staff that work in long-term care or hospitals or things like that. They did not recommend that, but they say that those staff may receive a booster shot based on that individual's benefit and risks. And then people aged 18 to 64 who are at increased risk for COVID-19 exposure based on occupational or institutional settings. So that's our folks. That's the same thing, is based on their individual benefits and risk, and that's may receive. Doesn't mean it's they should receive it, but may receive a booster shot based on their individual benefits and risks. And if you read through the slides, you can see where they differentiate and why they differentiate the booster shots for those over 65. It's because the data shows the real effect of the booster shot, or this big effect for those above 65, and less of an effect for those under the age of 65. And so that's why they did not say those folks should get a booster vaccine. Now, none of this speaks to Moderna, and I know a bunch of folks in Los Angeles County have used Moderna. Good news, even though it was not intentional by Los Angeles County, they didn't, I don't think we could guess that Moderna was going to be more effective than Pfizer, 8 months out, but it has held to be a little more efficacious for severe disease and death than the Pfizer vaccine. And so I think there is work on the Moderna booster shot, but the Moderna booster shot could be different than, and that's what I'm reading. I don't know that it's going to be the exact same dosage. So the Pfizer series is essentially the same dose again on the third shot. And whereas the Moderna, I don't know, it could be less than that. And that may be why there's a delay. I've heard that they're working on a booster shot co-administered with the flu vaccine. So I'm not certain why Moderna and Johnson & Johnson are lagging behind Pfizer in terms of the addition of the booster shots, but the FDA and ACIP felt that there was compelling reason to address boosters for those that took Pfizer in our patient population. So we want to get those folks boosters as quickly as we possibly can, I think. It's definitely going to have some benefit to our residents. I will say that, across the state, the numbers are trending down pretty dramatically, which is great news. Not in every part of the state, but in most of the state, it's trending down pretty significantly. And as a comparison to other parts of the country, holy cow, we're doing a lot better. So whenever you think it's bad, there's always somebody that's got it worse than us. But all right, so I want to talk about some Los Angeles specific stuff in here, and some of this is going to be applicable to folks outside of LA, especially as we talk about the CAOSH stuff. I want to highlight that. But Los Angeles County addressed or added new quarantine guidance for fully vaccinated admits and readmits. And I just want to let you know, this was added to their website on September 15th, and I was told that it was emailed out to the facilities. I did not receive the email, and I've heard from others they didn't receive the email. But in any case, just know that this went into effect on the 15th. That's the bad news. I'll give you the good news in a second. So, all new admissions and readmissions, regardless of vaccination status, should be quarantined in the yellow cohort for 14 days. All residents, regardless of vaccination status, who leave the facility for greater than 24 hours for either medical or non-medical reasons should be quarantined in the yellow cohort for 14 days. So that's the bad news. That was added September 15th, and I believe people have already gotten surveyed on this, and they're like, wait, what's going on? That's completely different than the state. The state says they go into the green. And so I had a conversation with some folks at LA Public Health. I don't know if it was my conversation or just me highlighting specific facts about secondary transmission, severe cases, and what we're seeing. And is that tied to data, or is that a knee-jerk reaction based on a single case? And it sounds like, well, they definitely did have cases of readmits going to the hospital without COVID, but coming back from the hospital with COVID, fully vaccinated, being put right into the green zone. And I asked, are we seeing transmission then from that resident to other residents? And, secondary transmission. And is that secondary transmission causing severe outbreaks or severe outcomes in the people that get COVID? And the answer was not much. And so my argument is, why perpetually isolate somebody and force them to stay in a room with the door closed, and not allow them, free movement, and not allow us to do rehab and all these other things that are unachievable while somebody's in a yellow zone. And I think we made a compelling argument. LA County is going to have a webinar directly after this webinar at 2 o'clock, and they will cover that they're going to change back to the state guidance. When that change back comes, I don't know. And she said, well, you know, we just changed it. If we change it back now, people are going to get upset. And I go, no, people are going to get upset if you leave it the way it is. Let's change it back and get it right, and let's go from there. So my hope is they're going to make the announcement on the webinar at 2 o'clock today, and then they will talk about, you know, kind of things to keep in mind, you know, when you're readmitting folks. Also, on the change to their website on September 15th, they added in this language, and I'm not certain, you know, this, it's appropriate for them to list this on there, but that's okay. CAOSH, this is the statement from their ACDC page, and then I'll talk about where it conflicts and where you can find the appropriate information. So CAOSH, this is on their website. CAOSH no longer allows for reuse nor extended use over multiple resident encounters in a single shift of the N95 respirators when used for respiratory protection for suspected or confirmed cases. Well, that is in direct conflict from guidance given by CAOSH and CDPH on the August 11th call that Eric Berg from CAOSH was on. And I'm going to just give you the answers that were included in the notes from CDPH. And if you listen back to the audio recording, you can hear Eric Berg clearly say that this would be okay. So while I understand what that says, here is what CAOSH has said as an allowance for extended use. When used as PPE, N95s obviously should be removed and discarded after each patient encounter. That's normal, and that's what we would normally do. However, if the healthcare professional is caring for multiple residents in the yellow or red zone that have the same infectious disease, the healthcare professional does not need to discard. I'm sorry, guys. I've been going. I wish somebody would have stopped me and said, "Hey, the slides don't match up." I apologize. Oh my goodness. I apologize so much, guys. I've been working on my own screen and not on the other screen. Oh my goodness. I'm so sorry. I apologize. All right. Well, I'll do the best I can from here on out. I apologize. All right. So when so the healthcare professional does not need to discard the N95 after each patient encounter if that aligns with the manufacturer's instructions. So if the manufacturer's instruction says that once it's donned, you keep it on, and if you doff it, there's, you know, you can only don and doff it 5 times before the straps become affected. That would be an example of the manufacturer's instructions saying that you cannot don and doff this respirator more than 5 times. But it does not say that you need to remove it after every interaction. It depends on the N95 and how long the instructions say it can be used. The CDC says the maximum you take an N95 off is 5 times, so we know that. After 5 times, the bands tend to stretch. As long as the N95 is in good condition and kept clean and doesn't exceed the duration of donning and doffing according to the manufacturer's instructions, then it can continue to be used with patients that have the same infectious disease. That's what they said on the webinar. That's what they put in writing. In the handouts today as this the call notes from that date, and I'm reading right off of the call notes. So you can have this. If a surveyor shows up and goes, "What are you doing?" You go, "Hey, this is from your boss right here, and this is from the head of CAOSH right here." So we have the 2 experts telling us exactly how to do this and where to do it. So, all right. Los Angeles County webinars today. Here's the link. At least I got the slides moving. I almost feel like going back and showing you the slides again here, guys. Well, maybe I'll do that while we breeze through the questions because that's the last slide I have. If you're in LA County and you want to check, check out early to get to that webinar, definitely. I asked Dr. Nie to cover the nuances of the N95 usage and how it's allowed to be used within the same cohort, provided they all have the same infectious disease. My hope is she'll be able to explain that nuance on the webinar, but if you get a surveyor, and I had a lot of people talk about surveyors are talking, we can't use extended use, and you go, well, extended use is a little bit different than what they're allowing, and whether we call it a modified extended use or whatever, maybe the terminology is not right, but certainly there's allowances for keeping an N95 on, for multiple patient encounters in the same cohort. And that just, it makes sense because the donning and doffing process is also presents a risk if you don't do it appropriately. All right, so I'm gonna hop to questions and I'll try to in the background maybe run through the slides here. So that you guys, oh God, I'm so sorry. What happens when you do all this alone, guys? I apologize. All right, so where did I leave off? Oh my goodness. All right. Was it there or was it there? I think that's where I left off. All right, in any case, I'll try to get through these. So first question, can we cohort vaccinated and unvaccinated new admissions and readmissions in double occupancy yellow room provided that both residents have low risk for COVID? Well, the rules on the cohorting zones are only set up by exposure. They're not divided up by vaccination. Although clearly the unvaccinated has a higher risk of both contracting it and having severe disease. I think the real overarching goal, or I think what the CDC and everybody that I've talked to says, the best practice is that if you have the room, to have each yellow in their own room. Now I realize that's not feasible, and if that's your case where it's not feasible to have them in single rooms, then there's nothing in the guidance that says exposed residents should be divided up within that cohort based on their vaccination status. I mean, it would depend on where the exposure risk was. Maybe they were in the green zone and they were roommates and they got exposed by a healthcare worker that dealt with both of them. If that's the case, I would keep them in the same room because the exposure was the same to both of them. And it's possible, that they have exposed now each other because they live in the same room. In that case, you might not even want to move them into another room with somebody else. If the only thing I would do is if you're going to move them, it's into a single room. I would keep them cohorted at this point. All right. As the capsulated COVID pay ending on September 30th. I don't know that, Vivian. I'll find the answer for you if I can from Jeff, and I'll try to put it on the forum. I don't know the answer to that. I apologize. Do we need to notify CMS each time we begin to use a different antigen test? I don't think so, no. As long as you're using them under your CLIA waive license and you're using one of the FDA EUA approved methods, then you're okay. How you document that, I don't know that if in the documentation it requires you to list out the type of tests. I think it just asks for positive and negatives, but I could be wrong because I don't have access to the CLIA reporting system. We've asked for like a user access so we could develop some, guidance to how to input things, but they won't let anybody that's not a licensed healthcare facility have access to that information. And but if you use the CareStart, I don't know that you need to notify CMS or CDPH of that. I think because it's approved, you're okay to use them. You're just gonna obviously we now know that you need to document both positive and negative tests. Third question here, 20 minutes in, says, your slides are not moving. I apologize. All right. Now maybe that was the last one I did. That's the Wednesday webinar link they had. Ah, yes. Okay. Here is the EEOC quote that I read earlier, and a link to that as well. And here is the information on the space blanket waiver. And it just says that if you're cohorting folks, you have the allowance to do that in the non-traditional spaces, but the bed's got to be 6 feet apart. Here's the link to the BYD mask I mentioned. I'm sorry, I'm so sorry, guys, I apologize. And here's the link to the 3rd shot booster doses. And that's the CDC link to the recommendations that I read off, the 4 recommendations. And here's the information on LA County and the new quarantine guidance. And the notes from the IP conference call are on the side in the handouts. Definitely that information is, I see folks get it all over the state as surveyors asking about disposable use N95. So definitely keep that at your handy if you get queried by a surveyor. So, all right. I feel like such a heel for not moving the slides, guys. I apologize. Anyways, hopefully you, if you have no further questions, I think I've covered all the material. Please, if you're in Los Angeles, tune into the webinar in a couple minutes. I'm going to go log in and see if I can learn some stuff too. In any case, and if you have questions about the exemption letter and you're not able to download it off to the website, please, jbelden@cahf.org, just send me an email, say, hey, can you send me a copy of the exemption letters with the guidance on how to use each one of them? And I'm happy to send that to you. All right, guys, if there are no further questions. Oh, a surveyor recently said that all N95 need to be fit tested. Yes, so if you, and that's a great point, Noah, thank you very much. And I don't mention that often, but when we fit test in N95 respirator, and this is really gonna suck if you have those BYD masks, but when we fit test to a specific make, model, and size of respirator for that specific employee, so that if you switch to a different make, model, size respirator, you have to go through that qualitative fit testing process all over again to make sure that they can get a seal on the N95. If now you don't have to do the medical evaluation again or any of that other stuff, because that's already done. That just says that they have the capacity to wear or they can be wear a tight fitting respirator. The respirators themselves are will be dependent on you know, that's the qualitative fit testing part, is the make, model, and size to that specific employee. Okay, another question: are facilities required to have a PAPR? Well, if you're doing aerosol generating procedures on somebody that is suspected of COVID or they are positive for COVID, then the requirement is to use a PAPR. I will say that prior to this, now that they've really kind of pushed this, because before we were talking about, well, we didn't have access to PAPRs or they weren't widely available. So it was okay to use N95s for aerosol generating procedures when you did not have the PAPR available. But now they've just gone to a strict, we want to see you have a PAPR if you're doing aerosol generating procedures on somebody with an airborne infectious disease. I will say in most cases, pandemic notwithstanding, in most cases, anybody that has highly infectious airborne disease is not going to stay in our facility. We're going to transfer those folks to an acute care hospital that has the capacity to deal with them. And then in those instances, it's not feasible or reasonable to have a PAPR because we don't ever keep people that have highly infectious airborne diseases. In a pandemic, we're going to be forced to care for those people because we don't have any other options. And that's why CAOSH has said, well, okay, you can't be a referring provider now you have to accept and keep these folks. And if you are, then what are you going to do if you have somebody that needs an aerosol generating procedure? The PAPRs are pretty expensive, 12 to 1,700 bucks, or 1,000 to 1,700 bucks per. They are permanent, or provided you care for them, they last a long time, but they're not cheap. But it's not necessary. I don't know where it's required by law that you have a PAPR. It would be a best practice to have a PAPR for sure, at least one. But Vivian, sorry, did not hear the answer about cap slide, but I will. Sorry, Vivian, I will ask Jeff. I don't know the answers to that. I apologize. I will ask Jeff Breen or Jeff Sandman and Jennifer Breen. I will ask one of them what the answer is, and I'll put it on the forum for you, okay? All right, so if we have no other questions, oh, wait, not to panic. We were able to figure out how to advance the slides on our end. Oh, okay. All right, good deal. All right, guys, well, hopefully you have a wonderful weekend. For those of you in LA, you probably already check out. Oh, yes, Heather makes a good point. A PAPR is also great if you have people that cannot be fit tested. So for those that cannot fit test to an N95 respirator, and you cannot find alternative work for them that would not require them to be have to wear an N95, then in those instances, you want to have a PAPR available for those folks, especially folks, not to call out men, but there are certain religious groups that have men have facial hair, and that's a big one. They don't want to shave their facial hair, but they need to have respiratory protection. And for them, maybe a PAPR is the only thing that works. Things like dermatitis around the face, or maybe you have severe asthma or COPD and you have difficulty breathing. All of those things could really affect your ability to wear an N95 and really could degrade the health of the person wearing it. So in those instances, if you cannot come up with alternate work accommodations that would not expose them, which in our case during the pandemic is pretty much anywhere in the building. So for those folks, definitely want to have a PAPR for those folks. Thanks for pointing that out, Heather. All right, guys, have a great weekend. If I don't hear from you, take care. We will see you next month. And obviously, if you're tuned into the HSAG calls, I'm on those every week as well. So look forward to hearing from you. If you have real concerns about staffing, please don't hesitate to reach out so that we can figure something out before September 30th, rather than dealing with evacuations after that. So, all right, guys, have a great, wonderful afternoon. Have a great weekend. Take care. Bye-bye.